Hi, I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation, Los Gatos Center. Welcome to Health Connections on KCAT Television, Los Gatos, Montessorino. On tonight's episode, my guest is Dr. Sangeeda Kopardekar from our Department of Geriatric Medicine and Palliative Care. Welcome to the show, Sangeeda. It's lovely to have you.
Thank you, Stuart. It's really great to be here.
Let's talk a little bit for our viewers about you. Would you mind telling us a bit about your background, where you're from, and your training?
So I actually grew up in India. I did my medical school and my medical school training from India, from a place called Ahmedabad. After that, I got married. My husband and I moved to the United States, and I did my residency and fellowship training from Philadelphia. I did my geriatric fellowship from University of Pennsylvania. And then he wanted to move to the West Coast, so we moved to the West Coast, and I joined the clinical faculty at UCSF. I was with UCSF for 4 years before I had an opportunity to work with Palo Alto Medical Foundation, and I've been with PAM for 10 years now.
I remember we met when you were interviewing.
That's right.
It's been a long time. It's great to be able to work with you all these years.
Thank you.
I appreciate that. I'm not sure that all of our viewers will know what it means to say you're a geriatrician. Could you start by explaining what that means?
So geriatricians are doctors who are internal medicine doctors or family medicine doctors who have completed additional training, fellowship training in geriatrics. We have basically specialized in caring, providing special care for people older than 65, and we take care of people from 65 to, my oldest patient is 101, but there have been people as old as 103 or 4. So there's geriatricians who practice in all kinds of medicine, primary care, but we have specialized in providing care in the nursing home, post-acute medicine. We work with people who are elderly, frail, have chronic, complex medical conditions, and really, I think, want to give advice and take care of people in terms of what's the way to age in a healthy manner, what's the way to optimize your quality of life, to continue to live in a very functional way in the community, and if additional resources are needed, then we can help and assist with that as well.
So, Sangeeda, it sounds like you're telling me that at the Palo Alto Medical Foundation, you and our other geriatricians take care of really the sickest of the sick or frail elderly folks.
That's right. At Palo Alto Medical Foundation, we have several programs. We take care of our sickest and frail elderly patients who are in the nursing home. That's our biggest program. We also have several geriatricians who provide consultation. For example, as primary care doctor, if you were to refer somebody who had recurrent falls or who are having memory problems, geriatricians are providing consultation services and assisting with care. And there are also some programs throughout PAM that are providing like shared medical appointments for people and giving advice on healthy aging. So I think geriatrics has a gamut of programs and we can help in different ways. There are not that many geriatricians out there. You know, there are less and less people getting trained. So I think our best way is to take care of the sickest and frailest and assist and support our primary care doctors in providing expert guidance.
So most of our patients over 65 at the Palo Alto Medical Foundation see a primary care doctor, either an internal medicine doctor or a family physician, or we do have some geriatricians who primarily do primary care in their medical practice. But you and your colleagues mostly work with the sicker folks.
That's right. So thanks for reminding me. There are great geriatricians who are providing primary care through the primary care department, but the geriatricians in the Department of Geriatrics are primarily working with older, frailer patients in different areas, you know, at home, nursing home.
So in all settings?
In all settings, yeah.
At the outset, I mentioned that you provide palliative care. You mentioned that as well. What's that? What's the difference between palliative care and geriatric medicine?
You know, that's a great question. And palliative care is in your specialty. The way I would describe palliative care is it provides specialized care for people with serious illness. And so they could be older people over 65, they could be people younger. There isn't an age limit for palliative care. And the real focus of palliative care really our focus is symptom management. We advise and provide guidance on advanced care planning, big picture planning, and also provide psychosocial support at home. So I would say that there is some overlap between what geriatrics does and what palliative care does, but palliative care is really very focused on the symptom management piece of it and quality of life. We see, again, sicker people, so you could see patients, for example, with stage 4 cancer. We would see patients with advanced neurological diseases. We would see patients with advanced pulmonary diseases, and our focus is how do we do pain control? You know, how do we make sure that they're comfortable? How do we meet them where they are? Some people are not able to come to the clinic, for example, so we can provide home visits. Not in all settings, but in some situations. In palliative care, we look at the patient and the family as one unit. We realize that any serious illness impacts not just the patient, but also their immediate family members and loved ones. And so we really look at them as a unit of care. And one other thing that palliative care, I think, really focuses on is coordination of care. You know, we have a very fragmented healthcare system. We have people who go from the nursing home to hospital. And we spend a lot of time, we have a lot of staff that actually works very closely in coordinating all those pieces of care. So we work very closely with hospitalists, home health, hospice, primary care doctors, and try to just provide a seamless care for our patients.
So a team approach to taking care of
It's a
these
team
very
approach.
sick people.
Exactly.
Are there certain qualifications for patients who see palliative care doctors? Do they have to meet certain criteria before they can become your patient in palliative care?
You know, ideally, I would say we would love to take care of everybody, but it's not possible. So I think the main thing I would say is they would need to be diagnosed with a serious illness. Now, for example, we can provide palliative care for patients who have been initially diagnosed with cancer, because we would work collaboratively with the oncologists, with primary care doctors, and focus on symptom control and quality of life. But more often, we end up seeing people who have more advanced cancers, for example, or have advanced illness. So it's still an evolving field. You know, we're still figuring out exactly where we can be helpful, but anybody with a serious illness can be referred to palliative care.
Very helpful for lots of folks. Let me ask too, you mentioned that you think about the family and the patient as a unit to care for the whole unit. But are there patients who have little or no family, or patients in the nursing home who might qualify for palliative care with you and our other colleagues?
Yeah, actually, that's a good question. We see, unfortunately, I think patients all the time who do not have support, family support or friends, and we can see all of them. We see all of those patients. One of the big roles then palliative care would play in that situation, because we are lucky enough to have our own social worker, is to find, you know, some kind of support system for that person to assist with getting, if they need caregivers, if they need, you know, to kind of do an assessment and figure out what kind of support systems that they would need, and then we would work with them to provide that and make that happen.
Sangeeda, can you think about a patient that you've taken care of recently where you called on members of the team to help you in putting together a care plan? And tell us just a little bit about that individual.
We are taking care of a patient right now on our team who has ALS, which is Lou Gehrig's disease. It's a very difficult disease to deal with. You know, it impacts people's ability to move, it impacts their ability to swallow, to eat, to talk even. And this lady is really struggling with that diagnosis. She has recently been provided a feeding tube because she got to a point where she couldn't eat. And there's a lot of emotional and, you know, family distress, a lot of emotional distress. So in this particular situation, we have our doctor, our nurse practitioner, our social worker, our nurse, all working together, trying to figure out what is the best support we can provide for this patient. And we are working with the neurologist very closely. The patient has made several references to the End of Life Act recently that has become legal in California. So there's a lot of complicated layers of care for this person, and our goal is to talk with her to figure out what her goals are, to assist with advanced care planning, to assist with coordination. You know, just getting a feeding tube and getting feeding started is a pretty big, complicated process of its own. So helping with that, working with our neurologist colleagues, you know, coming up with a plan of care. So I think there's a lot of layers, and it takes a whole team. In addition to the palliative care team, I think it takes the global team that is there at PAMF with the family members, and it's an ongoing process, which we work closely together on.
It's really lovely to hear you talk about your patient. I think our viewers can get a good sense of how compassionate you are and how the whole team works together to provide really compassionate care to our patients. It's wonderful.
Thank you. We love it.
You mentioned the End of Aid in Dying Act for end-of-life issues, but let's back up.
Sure.
There are other instruments, legal forms and guides that help you and me as a primary care doctor and other people who aren't from PAMF help our patients when they need it. So let me ask if we can talk about advanced healthcare directives. What is that?
I think that's a very important question, Stuart. So advanced care directives is called by several names. Some people think of it as a living will. It's an advanced directive. And it's typically people are asked to do that when they're doing their trust. They're creating their trust. Advanced care is part of that. But it's an important tool that we use. It's a legal document. And it's basically asking folks to do two things. One is to designate a power of attorney for healthcare. That is somebody who would make decisions for you if you are not in a position to do that for yourself. And that's really important because even for the healthcare system, we really need to know who is your designated power of attorney. And the second thing that they ask you to do is to kind of think about your goals and your life and how you would want your care to be provided if you were in a serious health situation. And so those are the two things that are addressed by an advanced care directive. And it can be completed by anybody at any time. So as a 40-year-old, 30-year-old, 50-year-old should typically have an advanced care directive. And I would say it's a legal document, but as a medical provider, to me, I see, again, as a geriatrician and palliative care physician, very often we run into situations where we see an older person who has dementia, can no longer make their own decisions, and have not completed an advanced care directive. And so there might be 5 family members, and we don't know who that they would want making decisions for them. So I think from care point of view, it's really important that people complete this and designate a person for a power of attorney for healthcare.
I would agree. In my family medicine practice, I've unfortunately been with families who have very seriously ill parents or other family members where maybe one child says, Mom would want us to do everything we possibly could to keep her alive forever. Right. And the other child says, no, Mother would never like to live this way. So let's take her off the ventilator, or she would never want a feeding tube. I've also been in situations where family members have been in disagreement, but we've had an advanced healthcare directive that has been completed in advance of the illness, and it says very clearly, this is what I would want done for me. And then I, as a physician, have been able to say, let me take this from your medical record, present it to the family, and then it's much easier for those folks who disagree to come to agreement.
Exactly.
So, and as you mentioned, at any age, basically I've had an advanced healthcare directive since my son was born, right?
That's great.
Just as part of doing a will and all those sorts of things. An advanced healthcare directive is a legal document.
That's right.
We can get copies online from the state of California and other organizations. Also on the PAMF.org website, if you just type in the search field Advanced Directive or Living Will, you'll find links to print out your own form. It can be signed by the individual and 2 unrelated friends or neighbors or confidants, or it can also be notarized, and that makes it a legal document. At PMF, we'd like to have a copy of the Advanced Healthcare Directives. We'll scan it into everyone's chart and then always have access to it. So let's move on to a different document. We mentioned the POLST, or Physician's Order for Life-Sustaining Treatment. Who needs that?
The POLST is another tool. It's a 1-page hot pink document, and it's a physician order for life-sustaining treatment. And it is usually recommended that people who have a serious illness, are older or frailer, would complete a POLST in addition to an advanced care directive.
And that's a document that stays in the individual's home.
That's right. So the POLST is a medical document. So there's a requirement of a signature by the patient or the durable power of attorney of healthcare and a physician to make it actionable, if you will. And the purpose of this, so the things that the POLST addresses are resuscitation, whether somebody would want to get resuscitated in case of cardiac arrest, levels of hospitalization, and their goals around artificial nutrition and feeding. And once those are completed and it's signed by the patient and a physician, it becomes completed. We would scan it into our system so that doctors and hospitalists have access to that. But the main purpose of it is it goes back with the patient, stays in your home. We recommend that you display it in a prominent environment, usually a refrigerator, but some people might not like that. And it's very useful if for any reason you need to call EMT in your house. They would follow that since it's a medical order. And so if somebody's goal was to not be resuscitated, then the EMT would basically follow that and not resuscitate. So we want to make sure that each person's goals are respected and honored. And this form is a way of doing that.
And not just whether or not we want to be resuscitated or if there's a problem, but also it can tell the emergency medical technicians that maybe you don't want to go to the hospital at all.
Right. That's
you'd
right.
rather stay at home.
That's right.
And as you mentioned, I usually tell my patients to put it on the refrigerator, and if you don't want it there, it should go in your medicine cabinet or wherever you store your medicines. Because when the ambulance comes or other public safety folks come to your home, if you call them, they will always look for all of your medicines and they'll find your POLST form.
Yeah. And can we also say that maybe discuss with your primary care physician before completing a form if you have questions, or with your palliative care team or hospitalist or any of your doctors that you know well, and they can answer any questions you may have about that.
A good time I like to do with my patients is when they come in for their Medicare annual wellness exam. We take time to fill out the POLST. Not every year. You only have to do it once, although it can be updated.
Right.
And mostly talk about it with folks who have more serious illness, but anyone can complete one.
Absolutely. And actually that's a good point, because people sometimes worry that if I put this in writing, that this is it stays that way, and that's not really the case. You can if you change your wishes or your goals change, you can always change and create a new form.
And just as we've been talking about discussing with your physician, having your physician sign it, both for the POLST and the Advanced Healthcare Directive, probably the most important thing is to discuss it with the family.
That's right. Actually, very good point, because I think in addition to designating somebody as a durable power of attorney for healthcare, it's also very important that your loved ones and your DPOA know what your wishes are. In addition to putting it on paper, discuss with your family so that they're aware of your goals and wishes. And again, the whole purpose of this is to make sure that your wishes are honored.
Many people are afraid of having that discussion. It seems awkward or inappropriate. But sometimes I've seen when we've had that discussion in the exam room in my clinic that a son or daughter may be relieved to have mom or dad talking about this because they just didn't know what to do.
Absolutely. I think very often families are grateful to have the doctors and their loved one have this conversation so they are aware of it. I think the advantage of having the conversation is sometimes we haven't thought about what we want. And so when we start talking about it, when we start talking to friends, families, doctors, is when we start realizing, okay, this is what I want, this is what I don't want. And then it's an ongoing conversation. Sometimes people might know what they want right from the start, and others might have to think about it. So the key part is the conversation with family members, with your physicians, with other experts, and then once you know what you want, to put it down in that document and make it official.
One more thing I'd like to mention before we talk a little bit more about palliative care, and I hope our audience understands that both of us feel strongly that these kinds of forms like the POLST and Advanced Healthcare Directives are an important part of knowing how we can best care for you. But one other thing I want to mention is that many Palo Alto Medical Foundation locations, not here in Los Gatos, but in Mountain View and some of the other larger clinics, we do have volunteers who are specifically trained to assist you in filling out your form. So if you don't have family close by, or you don't know what you would want, you need to discuss it with someone. We have folks who volunteer to help out other patients who come to see our doctors, who will make an appointment and help you fill out the form and get it scanned directly into your chart right at the time of that. If you're interested, you can ask your primary care doctor or contact our health education department. I know that a lot of folks who decide to come to see a palliative medicine doctor do so because of difficult pain management problems. How do you work with those folks?
So, symptom management is definitely a big piece of what we do in palliative care. And one of the most, I think, distressing and common symptoms we see is pain related to their serious illness. And I think the way we approach this is we do, first of all, a thorough history and physical exam, just like, other physicians would. We want to kind of talk about the characteristics of the pain. We want to understand where it is, what it feels like, does it radiate, all of those questions. What helps it better, what makes it worse. And then once we've gotten a little bit of evaluation, we've reviewed the history, we've gotten some idea of what's causing the pain, we will then work with our patients and families in coming up with a pain regimen that helps manage the pain. And our goal is always to manage pain in a way that optimizes people's quality of life. We don't want to give so much pain medicine that they're sleepy and not able to function. But we want to make sure that they have enough that they are not living with 9 out of 10 pain. We see very often people who come in and are very stoic and trying to be very brave. And when you ask more, they are saying their pain is 9 out of 10, which is pretty up there. And so our goal is to kind of really work with people, educate, come up with a good regimen that is safe and stable. We monitor closely, how it's working. We will titrate the medications and make sure that we've come on a medication that is working for them and helping the pain, and that helps them be functional and have a good quality of life.
What other kinds of things besides pain medicine can you do for folks to help them maintain their function or improve their function at home?
This is true for geriatricians and palliative care physicians. We work closely with functional status is a very big, important component of what we try to optimize. One of the modalities that is really good for that is physical therapy. And we will do an evaluation and assessment, figure out what the needs are. And some of the other things we can do is order home health, which is basically a skilled benefit through your insurance, through Medicare and other insurance, that will come to your home, provide skilled physical therapy, occupational therapy, maybe nursing care, speech therapy in some situations can be provided at home, and we will work closely with them to make sure that you're getting the right kind of care. There is a current program through Sutter, which is Sutter Advanced Illness Management, or Sutter AIM, and they are also our partners in this. There are several programs, I should say. One is a home health, and the other is Sutter AIM, which is more of a nurse social worker model. And we work closely with all of these to make sure that our patients and families are getting the right kind of care and that we are coordinating, together.
So again, another team approach.
It's a team approach.
You mentioned home health, home therapy, home occupational therapy, and physical therapy, but does everyone qualify for home therapy or home care?
Under Medicare, there is basically a criteria, which is somebody has to be homebound. We have some flexibility in determining that, but for example, people can go to their doctor's appointment or a hairdresser, but that it needs to be a hardship for them to leave their home, either because of lack of transportation or because of their functional inability to leave home easily. And we have to kind of justify that they are homebound before we can order home therapy. But there's, of course, if people are able to leave their homes, there's outpatient physical therapy, which is available through PAMF and other organizations, and we would, again, figure out how to make that happen.
Many or most of the patients you're seeing who are in the palliative care program are at home and have serious illness, many of them terminal illness. So let me ask what a terminal illness is, and then talk a little bit about hospice and how, what that is and how it plays a role in the care of folks with terminal illness and how you interface with the hospice care providers.
So terminal illness, again, under Medicare or under the clinical guidelines, would be when somebody has a prognosis of 6 months or less. So they have doctors in their clinical judgment think that they have 6 months or so to live. Under palliative care, you can get both curative illness and palliative treatments. Under hospice, you get primarily the focus is comfort and comfort and supporting people in their home environment. When the doctors feel that somebody has 6 months to live or a terminal illness, they become eligible for referral to hospice. Now, there's I think in the community there's a little bit of fear around hospice. The first reaction I usually see is a little bit people are afraid when I mention the word hospice. But I feel like it's a really important and an amazing service that's available to our patients in our community. They do a wonderful job of taking care of people at home or in their home environment and focusing on quality of life, supporting patients and family members, providing spiritual care, providing pain management. So it's a great resource that is available, that's underutilized, unfortunately. One of the big roles that palliative care does is tries to really do a smooth handoff to hospice. One of the things we try to do is get the right resource in at the right time for our patients. And I think hospice is an important resource when people come to that phase of their life journey. We work closely with our hospice partners. There are several excellent agencies in our community. Sutter has its own hospice. And we work with them, we collaborate with the hospice providers, with the nurses, and with the goal of providing this holistic care for our patients.
So it sounds like in some ways palliative care and hospice are quite similar. The biggest difference would be that palliative care may help patients who are young and old with illness that's not terminal, and may be involved for months or years in the care to help control symptoms. Whereas hospice care is aimed specifically at folks with a diagnosis of terminal illness, not anticipated to live more than about 6 months. Also young or old patients.
Right. And I think one other difference is, let's say somebody has cancer and wants to pursue chemo, radiation, all of the modalities of treatment, they can get that and be on palliative care. Once on hospice care, the focus has changed from treating and pursuing cure or treatment to comfort. And so sometimes it can be a little complicated to understand the difference, but those are the primary. So you can get both curative and palliative care on palliative medicine, and your focus is comfort care when you're on hospice.
Sangeeda, we're getting into some pretty heavy conversation here about difficult topics, some that aren't always easy to discuss, but I know that you really enjoy the work you do, in spite of the fact that you're taking care of very sick people, people with terminal illness. And in fact, I know that as a primary care doctor, sometimes helping folks at the end of life can be just as rewarding for me as when I've been there delivering babies.
I completely agree. I think I love doing the work we do. What makes us really great is the team that we work with. We support each other. The stories we get to hear from our patients are pretty incredible. And I think it's a time when we can really be of help and we can really intervene with the modalities we have to try to make somebody's life, comfortable, to try to help them meet their goals. I think palliative care is a little different way of providing care. It's goal-directed care, and a big part of what we do is to elicit goals. Some people might think having dignity as they get older or sicker is more important. Others feel like they have to take the trips that they've planned, So all of these things is what makes it really worthwhile and fulfilling.
You mentioned dignity. And I know that in this past year, prompted by very ill patients or the families of patients who've been very ill and passed away, that we have a new law in the state of California that folks who promote it see it as a way to help people maintain dignity as they're dying. So we call it the End of Life Option Act. We think of it as aid in dying. And it's controversial. Some people are very strongly in favor of it. Some people think it's horrific, and that's true both with patients who are ill, their families, and healthcare providers. So one nice thing I know about the bill is it allows people who don't agree with the principles of it to opt out. But for the most part, patients who are concerned about their terminal illness and not really want to suffer or continue living, they have the option now to talk to a doctor about ending their own life. Could you explain a little bit about how that works?
Sure. So it is a challenging topic. It's a new law in California. The main thing, the law lays out very clearly what are the criteria that somebody would qualify under this. And the main criteria are they need to be 18 years or older, they need to be residents of California, there needs to be 2 doctors who basically agree that they have a diagnosis that is serious and life-limiting, and that their prognosis is terminal, which is 6 months or less. And I think the other important part of the law, though, which can be controversial, is that they need to be able to self-administer the medication. So family might be able to help with mixing the pill, getting it ready, but the patient needs to be able to self-administer. And these are the main parts of the law that the doctors. Now there is a lot of documents and lots of criteria that the physicians have to go through to if somebody presents them with this request. But I think it's one more modality that is available to our patients to determine their goals and how they want to live and die. I think as a palliative care physician, I feel very strongly that people who want to take advantage of this law should have access to palliative care and hospice care. And some of the things I worry about are people making this request because their pain is not controlled, or because they're suffering in other ways, in which we could be able to help with. And one other thing that I worry about sometimes, because I think the cost of long-term care in this country is pretty expensive, is there any kind of coercion? Is there personal or family? So those are the things that we have to assess for before we move forward. And those are the things that I think doctors will be looking for if somebody comes to them with this request.
Sangeeda, thank you for speaking so compassionately about a very difficult issue. I know that you and the geriatric and palliative care team will take wonderful care of our patients, whether they simply need more support and care to help meet their goals, or in the event they may choose to take advantage of the End of Life Act. I do want to make sure that our viewers understand that there are relatively small numbers of folks who actually seek out help with physicians with end of life, with aid in dying, based upon the experience in other states where it's been legal for a while. I don't know if other doctors at Palo Alto Medical Foundation have helped patients so far, but please remember that each individual physician is allowed under the law to look into his or her own conscience and decide, would I rather not participate and refer this patient elsewhere, or ask that folks who are asking questions about aid in dying look on the website to get information? Or am I someone who is comfortable talking about it, but not comfortable providing the medication? Or am I someone who's willing to help patients right through to the end if that's what happens? But our patients should always feel free to look on the website or to speak to their primary care doctor about how they can get additional information.
That's correct. Every physician will be kind of on this journey as well, trying to figure out if they feel comfortable being a prescriber or not. But under the law, it's important to note that every physician can make the decision on their own whether they will participate or not.
Well, on that somber note, I'd like to thank our viewers for joining us for this wonderful talk with my colleague, Dr. Sangeeda Kopardekar from the Department of Geriatric Medicine and Palliative Care, today on Health Connections, KCAT Television, Los Gatos, Monte Sereno.